Welcome. Um, Welcome to another session of Zooming Through ID with Dr. Gopal. For those who don't know me, I'm Dr. Gopal. I'm one of the infectious disease specialists who has been in the area for almost since 2005. I trained at Duke University and I've been practicing infectious disease. One of the most rewarding um, aspect of my work is teaching. I love teaching. And whenever internal medicine residents rotate with me, I give them a uh, topic to research, and they present in this session. It gives them an opportunity to deep dive into the topic, and I think that is the best way to learn. Today we have Dr. Ashley Campbell. She is going to present. The topic is encephalitis. So I'm excited to hear what Ashley has to share with us. So, Ashley?
Thanks, Dr. Gopal. So I'm going to just share my presentation right now. What I did was just looking at two different articles that we talked about. So one from 2008, the comparative insights from the IDSA, and then a more recent article from Modern Practices in 2023, and just looking at the acute management of acute encephalitis, the guidelines and the advances. So just a quick introduction. How do we define encephalitis? So acute encephalitis is characterized by blurring inflammation, often resulting from an infectious or autoimmune cause. The significance of this is that it's a life-threatening conditioning that requires rapid identification and management, and outcomes heavily depend on early intervention. So the objective of this presentation, like I said earlier, is just to look at the IDSA guidelines from 2008 and compare it to the guidelines from the Modern and Diagnostic Therapeutic Insights from 2023.
Okay, great. One clinical aspect I need to bring up is, whenever we have a clinical scenario, we have to differentiate between encephalitis and encephalopathy, because encephalopathy is more like altered consciousness, confusion, disorientation, and there can be some behavioral changes. That is usually caused by metabolic as well as toxic condition, and that most scenarios it will be that, but then differentiating that from encephalitis is something that we usually have, in clinical setting. Yeah.
Right. So etiology of encephalitis. So back in the 2008 article, they talked about viral being the most common cause of encephalitis, HSV1, the varicella and West Nile virus being the three top causes, and then non-viral causes such as bacteria, mycoplasma being like a prime example, fungi or parasites. In the 2023 article, there is a major emphasis on autoimmune causes of encephalitis, including anti-NMD and
NMD.
NMDA,
Mm-hmm.
anti-LGL1, and the GAD65 antibody syndromes, as well as newer infections such as Zika virus, chikungunya, and Nipah virus.
Uh-huh. So, worldwide, when we look at it, there has been, cases of rabies, measles, and Japanese encephalitis and all. Annually, there are more than, like I would say, million cases. HSV is very common, here that we usually encounter. Yeah.
And then here's just a little chart with the data set here. You can see that, like you said earlier, HSV is very common here, especially in like the younger population. And like as the population gets older, for some reason, we can't seem to figure out why they're having encephalitis. Unspecified being the most cause in the older population. So clinical presentation of encephalitis. So core symptoms include fever, headache, altered mental status, seizures, and focal neurological deficits. In some autoimmune cases, you can see psychiatric symptoms as well, such as psychosis or memory loss. And then in the clinical setting, some of the red flag symptoms we must look for is if the symptoms rapidly progress, or if the patient has had a recent travel history, or if they're on any type of immunosuppressive drugs. And just another photo on the side here with all the symptoms we just talked about.
Yeah. Mhm.
So,
Yeah, before we go into the diagnostic, I'll briefly talk about, the HSV encephalitis because it is the most common. And the HSV encephalitis has about more than 70% mortality, with if you don't give them effective treatment. So that's why it's very important. It can occur throughout the year. We can see that, and it can be seen in all ages, but elderly, we see them. Usually in the hospital, we may see a patient with personality changes in an elderly. It present like that, fever. Sometimes they come in with dysphagia or autonomic dysfunction. Usually, majority of the cases are due to HSV1. Um, in terms of the diagnostics, you're going to talk about it, but with the imaging studies, the MRI has greater than 90% cases. It is very predictive. And there, we don't do any brain biopsy or anything for HSV, but if they do it, they will see intranuclear inclusion bodies in greater than, 50% of patients. But mainly the MRI would be, temporal enhancement will be seen. Um, and then in terms of the CSF presentation with the HSV, you're going to, yeah, once you say that, I'll say, but classically we'll see a lymphocyte pleocytosis. But yeah, go ahead. Yeah. Mhm.
so for diagnostic approach, so from the 2008 article, in terms of laboratory approaches, lumbar puncture for sure, like you were just saying with the CSF analysis, or you can also use PCR to look for HSV. MRI is the gold standard imaging when we're looking for encephalitis. A EEG can be helpful in detecting subclinical seizures or if the patient's having encephalopathy. And the 2023 article talked about next generation sequencing to look for pathogen detection in the CSF, as well as completing autoimmune panels since we're now able to detect antibodies that are linked to the autoimmune encephalitis and some biomarkers such as neurofilament light chains to look for the severity of the assessment.
So for the HSV, I mean, like the EEG, sometimes, there can be some epileptiform discharges can be seen, but it can be non-specific. But sometimes you see that. The main thing in the CSF for the HSV encephalitis would be when you do the CSF, there will be lymphocyte predominant pleocytosis will be there. And there can be red blood cells in the CSF analysis in the HSV. But although 25% cases, they don't have RBCs in there, but if you see RBC, that is more indicative of that. And then the protein will be elevated, but those are the main thing. And CSF HSV PCR has a very high sensitivity. It's about 98% sensitive. And the specificity is about 94%, but sensitivity is very high. Although I have to say that if somebody clinically is looking like HSV encephalitis, and then if you do initial CSF, if it is negative, but clinically, if it is, very high suspicion, may need a new CSF sample in, like 3 to 7 days. But in scenarios in the hospital, we end up giving them treatment and they do very well. And the treatment is like acyclovir and, 10 milligram per kilogram, 3 times. That's what we do. In terms of other viruses, we didn't talk in detail, but I'll quickly tell. Varicella zoster, and that can be cause of encephalitis. It can occur without any rash, and then they may have seizures or focal deficits. The CSF PCR can be done. We can send a CSF PCR. MRI, I mean, it's not like anything specific, but there may be some ischemia or something. Um, for VCV, acyclovir, we use it, but it's not completely, we don't have any controlled studies to prove that acyclovir is good. Then EBV can cause an encephalitis and transverse myelitis, and that also the CSF testing is PCR testing. Cytomegalovirus is another virus that can cause encephalitis picture. And mainly we see that in immunocompromised people with HIV. We can do again CSF PCR testing can be done. But the treatment for cytomegalovirus is ganciclovir plus foscarnet, not acyclovir. HHV6 is usually seen only in immunocompromised patients. We don't see it in a normally or in a normal non-immunocompromised patient. So if you see HHV6 in a question with a normal human, normal immune status patients, usually a, distractor. I wouldn't worry about it. Then the big thing is about the big item that the encephalitis is West Nile. West Nile, it is mainly mosquito-borne, and there can be other modalities like blood transfusion or, transplanted organs and stuff like that can, cause. Um, Mainly, it's encephalitis picture is the most predominant one, more than 50% of cases. Sometimes we see meningitis. And then the diagnosis is CSF IgM for West Nile, and that is usually positive in 90% of cases. Serum IgM can, be there, but usually we see that after a week, 8 to 14 days of illness. That's when we see that. There is no treatment for West Nile encephalitis. Unfortunately, it's mainly supportive care. You can do ribavirin. Ribavirin and all, I don't think it works. So it's mainly supportive care for West Nile. And then, of course, there are other, like the Japanese encephalitis, all the other arbovirus, tick-borne encephalitis, the equine encephalitis. Those are all there, but there's only supportive care for them. Measles is a big thing in developing countries. Measles can cause encephalitis. There is an entity called subacute sclerosing panencephalitis, that is SSPE. That is something that we see with measles, and it causes, seizures, death, and, coma. And it is the measles. Usually, I mean, it can be, if you get a board question, it can be a patient who is unvaccinated. I mean, not vaccinated. That can be. Yeah.
We say that they didn't receive their childhood vaccines or something like that.
Yeah, they will be, saying that. Yeah. Okay. Diagnostics. Yeah. Text.
Okay. So some of the management, the 2008 article talked about, and like you said, Dr. Gopal, high dose IV acyclovir for these suspected viral causes of encephalitis. Comparing to the 2023 article, we still use high dose acyclovir. And the newest approach now is early immunotherapy for the autoimmune causes of encephalitis.
Yeah. One thing I forgot to mention is, I'm thinking rabies. Rabies is something that we missed to talk about. It's basically encephalitis, worldwide. It's usually dog is the, dog bite will be the one. Sometimes, unrecognized bat bite or something they will say. It is very, very high mortality. And so the incubation period is actually long. It can be even up to 90 days. It can cause like a paralytic form of rabies. It can cause like ascending paralysis can be seen. And people will have, people with rabies, it's a devastating condition. They have this hydrophobia, like fear for water. And then hypersalivation can be seen, bizarre, behavior. It causes coma and death. So that is something very important in terms of, the dog bite and all that is, yeah.
Okay. So aside from the antivirals or the immunotherapy, we also want to provide supportive care. So can make sure we're controlling seizures if patients are presenting with seizures, make sure their intracranial pressure doesn't get too high. So whether treating with mannitol or um, hypertonic saline, as well as managing their fluids and electrolyte balance. And then once we confirm the etiology of the encephalitis, we adjust the therapy based on the confirmed etiology. So if it's a bacterial cause, we'll switch from antivirals to antibiotics necessary.
And like you said, the autoimmune condition, the anti-NMDAR encephalitis, that is something that is, it's basically a neuronal antibody associated encephalitis. And, there is a female predominance for that, female to male, the ratio is about, you can 8 to 2 or something. There is an association with ovarian teratoma. That is something that needs to be, you have to remember that. Um, and that one, the treatment is completely different. It's not it's corticosteroids, and IVIG can be given, and sometimes you have to do um, plasma exchange, and rituximab can be given for that. Yeah.
Okay, so
So
just
they have, yeah, the
so
cyclophosphamide and all those things. Yeah, the autoimmune encephalitis.
right. So pathogen-specific management. So for HSV encephalitis, the treatment's typically acyclovir 10 mg per kg every 8 hours for 14 to 21 days. And we adjust the duration based on the patient's clinical response. And typically we would want to repeat the PCR to see if the treatment is working. For autoimmune encephalitis, it's important to start immunotherapy early. So steroids, IVIG, plasmapheresis, as well as rituximab are often used. Other pathogens, so if it's something that's fungal, amphotericin B is typically what's used. And then for bacterial causes, we use directed antibiotics depending on the bacteria. So for example, if there's some kind of meningitis associated pathogen, we typically use ceftriaxone. Anything you wanted to add here, Dr. Gopal?
No, I think like you said, viral. I mean, we are focusing on encephalitis. So mainly we talked about acyclovir and then bacterial pathogens. Yeah, it's like meningitis and, this is completely, yeah, different. A lot of etiologies for that. The problem is with encephalitis, it's very difficult sometimes to diagnose. They had the issue is there can be many reasons. We may not identify a pathogen for encephalitis on some scenario. Sometimes a wrong test may be sent out. Sometimes it may be a wrong timing when we do the test. Uh, Sometimes it can be a uncommon presentation of a common pathogen. So there are a lot of factors for encephalitis, and in some scenarios, it may not be an infection. So that's why this encephalitis is very important to identify. They did there was an article that they published in CID in actually a long time ago, like just after my training. It was around, I would say, 2006 or something. It was a very interesting project they did in California. It was called California Encephalitis Project. What they did was a group of people, they analyzed about more than 1,500 cases. Okay. So they said all the physicians in the state of California, if they don't know what is the cause of encephalitis, they were sending them, the CSF for further analysis. And then this group will send out every panel that, all the research panels and look at it for all the aspects of encephalitis. And at that point, they confirmed that 69% of cases, more than I would say, I think it was about 68 or 69% of cases were viral. And then they couldn't identify confirmed etiology in majority of the cases. They only identified the definitive, among the viral, I mean, what is the pathogen? I mean, it was very low percentage. It was less than 20%, if I remember, so that is why it is always a challenge, and it is good to, it's great that we are talking about it. And
Okay. This is just a chart with what we talked about earlier. So complications and prognosis. So acute complications include seizures, cerebral edema, and autonomic instability. Long-term outcomes, patients can have cognitive impairments, motor deficits, epilepsy, and we noticed that rapid initiation of therapy leads to improved outcomes. So the earlier we can get a diagnosis and start treatment, patients have better outcomes long term. So prevention strategies. Vaccination is the big one. So getting a routine immunization such as MMR and varicella. And if our patients are going to travel, it's good to advise them to get their travel-related vaccines. If they are going to areas with known viral causes, like for example, Zika, we can make sure that they have mosquito nets and insect repellents and just sanitization of their environment. And then of course, public health measures. So make sure that if there's a rapid outbreak, we're surveilling and responding appropriately. So advances in diagnosis and therapy. So earlier we talked about the next generation sequencing. So basically this can help us detect pathogens in the CSF. For autoimmune encephalitis, there's improved protocols for immunotherapy now. And in the future, the article talks about maybe using AI to assist in diagnostics and getting targeted biologics for some of these autoimmune causes of encephalitis.
that is interesting. I mean, AI based, right? Yeah. Just in terms of the CSF right now, what we have, the biofilm array that usually that will test for, Neisseria meningitidis, strep pneumo is there, they have H influenza is there, the panel, the encephalitis panel that we send out from our hospital, and that also has the HSV1 and 2. I mean, HSV1 is there, and then the human herpes virus, HHV6 is there. That can be a distractor. Sometimes, like I mentioned to you, in an immunocompromised patient, it is a problem, which is, usually transplant and all. Otherwise, it is not a problem. And then they have some other gram negatives. And I think cryptococcus, crypto is also in there. Cryptococcus neoformis is also in the CSF panel. So that is amazing. Earlier, earlier we didn't have this panel. So this is immediately after we do the CSF, if we do the encephalitis panel, we can get, multiple pathogen identified, and that itself is amazing. And with the new AI trend, it will be even faster, I'm hoping.
Right, because earlier treatment leads to better outcomes.
Mhm.
So yeah, that's pretty much conclusion. So early and accurate diagnosis is the key to managing encephalitis effectively. Advances in autoimmune encephalitis have transformed care, and of course, continued research is critical to address the new pathogens that are emerging.
Okay, fantastic. So good job, and hope you learned something new from the article. And excellent. Okay.
I had a patient this week actually that we're
Ah,
suspecting HSV encephalitis, and we started a cyclovir
and
prophylactically. So
yeah, yeah, yeah. I mean, I've seen that, in elderly from sometimes from home or something, they start acting weird. And, once we start the cyclover and there is improvement and it is treatable and curable, so that is the main thing. Okay. Okay, great. Have a good have a good weekend. Okay.
thank
Nice
you.
talking to you. Okay, bye. Thank you.